Aspirants, this is going to be a very interactive session. The topic for today is trauma and burn, and it will be taken by Dr. Arun Thangavel, sir.
Thank you, Nidhi. Yeah, we have a small group of students today, but it's okay. We have an interesting session today. So I think last class we covered better about basics of trauma and burns, and I couldn't touch upon traumatic brain injury. So this session is going to be entirely on traumatic brain injury. So you are in safe hands again with Farz Academy. I can assure you with the Farz Academy classes and your preparation, you will definitely pass EDIC 1 so easily. So let's keep it interactive. This is going to depend on, the teaching is going to depend on your involvement and answering with the questions. So maximize your benefits by treating this like an actual mock exam and be involved. If possible, keep the videos on so we can interact better, and we will practice some MCQs along with the theory behind that. And at any point of time, feel free to interrupt and clear your doubts. So here we go. So what I want is either type in the comment in the chat box your answers so I can see it, and or else you can unmute yourself and answer yourself. Yeah. Fine. Everyone happy? So these questions we covered last time. So let's move on to trauma part, traumatic brain injury part. Yeah. This is our first question. 45-year-old male is admitted to the ICU following a severe traumatic brain injury, GCs of 6. An intracranial pressure monitor is placed. What is the primary goal for managing his cerebral perfusion pressure based on the current guidelines? Yeah, go ahead and you can type in the chat or unmute yourself and answer. Yeah. Nice. Yeah, it's pretty straightforward, right? 60 to 70 is the target font, which is correct. And this is what basically cerebral perfusion pressure is just the difference between your mean arterial pressure minus the intracranial pressure. In other organs, we subtract the central venous pressure, but for the brain, intracranial pressure is more relevant because it's a tight space and closed environment. Remember the Monroe-Kelly doctrine, so that's why we use intracranial pressure in this formula to determine the cerebral perfusion pressure. And the Brain Trauma Foundation clear-cut guidelines say the cerebral perfusion pressure should be between 60 to 70, which is ideal. In the management of a patient with severe traumatic brain injury, which of the following is a level 1 recommendation from the Brain Trauma Foundation? Yeah. Background noise. Ignore that. What's the level 1 recommendation in the given options? So level 1 is basically high quality evidence for those who are not aware. It's like based on systematic reviews and meta-analysis. Level 2 and level 3 is more like single randomized controlled trials or not clear-cut evidence available based on randomized controlled trials. Fahimudin says, hey. Any others, what do you think? Brain Trauma Foundation guidelines are quite important in the traumatic brain injury guidelines. and we should be well versed with the traumatic, all the recommendations from the Brain Trauma Foundation. It's really important for clinical practice as well as your exams. Yeah. So I agree with you, Hilal, and appreciate you are correct. It's C. It's the only, I mean, level one evidence. All the rest of the evidence are based on like small randomized control trials or consensus statements. So this is
Recording in progress.
corticosteroids. It's a definite no.
Corticosteroids, it's a definite no. Corticosteroids, it's a definite no. I'm just trying to log in from another. To log in from another. To log in from another.
It's difficult to see both the comments and words on the meeting, just the presenter mode, but it's fine. So yeah, corticosteroids is the right answer. Patient with severe traumatic brain injury is being ventilated. The ECM suggests like hyperventilating for a bit, increasing the respiratory rate to drop the PaCO2 to 30 millimeters of mercury in an attempt to reduce the ICP. So what is the major risk of this strategy? Metabolic alkalosis, worsening hypoxemia, cerebral ischemia due to excessive vasoconstriction, increased cardiac output, and hyponatremia. Yeah. So it's understanding of the physiology, right? The cerebral blood flow is dependent on the CO2 levels. And if you see this chart on the right, so the green trace I'm showing is the PaCO2 and cerebral blood flow. You might have seen this on Miller's textbook of anesthesia. So the lower the PCO2, the lower the cerebral blood flow and the risk of cerebral ischemia. So you are all correct. Let's move to the next question. Patient with traumatic brain injury develops polyuria, more than 200 mL per hour of dilute urine and rising serum sodium and osmolality. So what is the diagnosis here? Yeah, I got all simple questions for you guys. Yeah, few tough ones, but you'll see in the end. Yeah, diabetes insipidus. So how do you treat it? How do you treat diabetes insipidus? Yeah. Yes, of course. Desmopressin, right? So if can the reverse happen? Can the patient develop hyponatremia with a traumatic brain injury? And what are the differential effects like hyponatremia? Yes, bang on. And yes, Abhishek, how do you differentiate cerebral salt wasting from SADH? It's easier to talk, you can unmute yourself, but I'm happy with the text. Yeah, just follow the chat box, everyone, because lots going on in the chat box. Yeah, it's very difficult to differentiate clinically cerebral salt wasting and SADH. Main thing is the volume status. So SADH is more kind of euvolemic, and the other is a bit of hypovolemia. And yes, as Abhishek says, that's the other factor, but it depends mainly on the volume status clinically. But I agree, it's difficult to differentiate most of the times. All right.